Let me know when you're good, Brian. All right, awesome. Hi, everybody. I'm Jenny Paxson. I'm the Adult Services Librarian here at the Webster Public Library. And I do our Reader's Discovery, Reader's Advisory help, finding a book in here. And I also do all of our programs for disability services for caregivers and for people with disabilities, getting information out there about the great resources we have in the community. Very lucky to do these panels, the Disabilities Dialogues, every month. This one is on GI issues, and next month we will not have one because we're having our college and transition fair for people with developmental disabilities on Saturday, August 8th. So if you know of someone who is transitioning out of high school or moving on from when the bus isn't going to pick them up anymore, this is a great event. We'll have people from colleges and workforce development and housing and different resources from the community here to give you information. Our next panel will be in September, on September 8th. It's on advocacy. It's at 11 a.m. We're moving these to Tuesdays just for the ability for our partners to be able to make it, and for a lot of our presenters, panelists found Tuesdays to be easier, so we're transitioning to Tuesdays starting in the fall and today. And so I'd like to thank our partners, Autism Up and Parents Helping Parents Coalition of Monroe County, for being here and supporting this event. And without further ado, I'm going to get into our panel today, and I'm just going to have you all here go through what you do, who you are, what you do, and kind of a little bit about, the services that you provide. All right? There we go.
All right. So my name is Rachael Mallory. I'm a pediatric dietitian in GI, and our group here works mostly in the we call ourselves the PANS program. So Pediatric Advanced Nutrition Support. So a lot of children with feeding difficulties, feeding tubes, and things like that.
I'm Colleen. I'm one of the nurse practitioners that works in the PANS program. We follow all the kids with feeding tubes and IV nutrition as well.
Almost forgot.
Yes. And kids that just aren't growing well. And do general GI as well as advanced nutrition.
And then I'm Andrea Taylor, and I'm one of the dietitians as well within the PANS clinic.
So I know a lot of people probably ask, is my child eating well? Because my daughter for a long time, or my son, all he wanted to eat was Lunchables. And so what is a good diet? And is eating the same types of foods all the time, is that okay?
I can take this one or start with it. I feel like one of the big ones we get with a similar question is, my kid will only eat carrots. And I say the best vegetable you can give your kid is one that they'll eat. Mm-hmm. If you have, 2 vegetables on hand that they'll eat, and you rotate between those, great. So any one fruit, any one vegetable, and having a couple options is great. We prefer variety, mm-hmm. but being able to incorporate those in fun ways and ways that they'll enjoy and continue to eat, I think is important.
So what do you think is, I know you said eating one fruit and one vegetable, what do you think is a good diet, especially for kids who are developmentally disabled? What would you recommend? I know that, they say the food pyramid, I know that's changed a little bit recently, but, but when I was a kid, it was the carbs on the bottom, and then, the fats and the sugars at the top. And as I always struggled with that, and it's harder with people with limited food choices because they have food aversions or whatever.
Right. So as far one wonderful resource that we have at our hospital is we have feeding therapists. So if we have children with further needs on, like you're saying, oral aversion, things like that, we refer them to a specialist who can help them determine if they're having mechanical issues, chewing, swallowing, things like that. Is it safe for them to do so? Is there a reason why they're not picking certain foods? So then we can dive further into the diet aspect and the food choices.
Got something to add?
Yeah, no, I mean, I think it's, every child is different, and just trying to offer things repeatedly. I have a picky eater, and so what I've tried to do is find, can I bridge to something healthier? And just focusing on the foods that she will eat. So, really optimizing the foods, the healthy foods, offering those more often, but also offering the newer foods. And it's, it takes just repeated exposure, working with therapists to see, how to help them.
Well, and what's my favorite number, I think, is they tell us you have to offer something 10 to 15 times before it can be accepted, completely accepted or completely rejected. Okay. That's a lot of times. Yeah. So just because, going off what Andrea's saying, just because you offer something once and they don't necessarily eat it or they say no, offer it on the plate again, offer it in another setting, offer it around their peers or school, snack time, playtime, things like that. So,
yeah.
My daughter is at Mary Cariola, and they finally figured out that she has she's not rotary chewing, she's not chewing correctly. So she's in a chewing clinic, and they do try different foods with her. She's definitely pushed away quite a bit because they send a report all the time. So with that, issues with the chewing though, she often will swallow foods whole instead of chewing them properly. Does that have any impact on GI issues?
Ta-da! My turn.
What do you think?
It can. You can still digest the food. It's going to be digested in the stomach. Parents are always concerned when food comes out the same way it went in, and when it comes out in their stool. And sometimes that does happen, but for the most part, your stomach is pretty strong and still going to be able to do the work and break down the foods. So yes, if they can get it. We worry more about swallowing foods whole if they're going to choke on it, or if they do choke, are they going to aspirate and things like that. So then we have to do other medical tests to figure out what's going on. But yes, if they swallow it whole, it still works just as well.
I always worry that my daughter is going to aspirate. Is there a good way to tell that they've done that, or do you just have to kind of wait it out and see if they end up with pneumonia or something like that?
Yeah, it's tough because kids can have silent aspiration where you don't know. They're not choking, they're not gagging, they're not coughing, they make no sounds. You don't know that things are going down the wrong way. The only way is if they develop a pneumonia. So unfortunately, it's just a wait and see. Obviously, if you can look at your child while they're eating and see them physically having issues, or if things look like it's going down the wrong way, they're gagging, grimacing, making faces or something, then it's something we need to evaluate.
What kinds of tests do you usually do with new patients or with people having those kind of issues with?
We rely heavily on the speech therapist. We work with Kat Maruska usually, and she's wonderful at doing bedside evals, so she can just watch kids swallow and see what muscles are working or not working, and whether or not they need a pharyngogram, which is a swallowing study under x-ray, so we can actually watch the food go down. That's the best way to know whether they're silent aspiration or not. And then based on those results, we can determine, do they need a thicker food? Do they need cut up in small pieces? Do they need to space their foods? Are they pocketing foods in their cheeks, which is very common? Do they chew and spit it out, and why are they doing that? So that's the main test we do to start with, and then we'll see if there's other tests.
I know I kind of been asking some questions that I have, but what types of typical questions do you get asked by parents? What's your big questions that you get asked?
I think most often they want to know if their child is growing appropriately, you know, are they eating enough?
Are they eating enough protein? I feel is a big one we get a lot.
Yeah, especially with how I feel like, you know, the food industry, everything is protein added, you know? And that's not necessarily the case of what kids need.
And it's fun too to do, one thing I like to provide is giving an idea on what portion size looks like for age. So, you know, a 3-year-old may be eating enough food in a meal, but for some reason will think that they, you know, aren't eating enough for their size, and just reassuring, you know, you're providing a good balance of foods. You have, like you're saying before, there's a carb, there's a protein, you have a fruit or a vegetable.
How do you know, like, if there's like an issue, like a failure kind of to, like, if they're not growing correctly? How would a parent know that?
I mean, we review the growth chart each time we see a kid, and so I like to review it with the parent and kind of show them where they at and where they're trending.
I think that's probably one of the main things we look at as a starting point to say, okay, I don't think my kid's eating enough. And if they come in and we have a couple points in a row on the growth chart showing that they're growing adequately, that shows us, okay, they are getting enough calories at least to grow, and we go, you know, can go from there.
I like to look at the child because, and I always tell them, all the dietitians when they come, is that the charts are good, but they don't tell the whole story. You have to look at the patient. Because if the growth is way below the growth curve on the weight chart, but their height is way below as well, then their BMI is going to be perfect. So for their height, their weight is okay. Then you got to look at the family and their genetics. How tall is mom? How tall is dad? What is their body proportions like? What is mom eating? Is mom not eating at all? So that way the baby's not eating or the child's not eating because she doesn't eat meals with them. What's going on in the family? So I look at it from a whole systems point of view as well as other things. And they do too. They just didn't say
answer
it.
that one.
Yeah.
Well, and one thing that, you know, there are different growth charts as well for different diagnoses. So that's one thing too for parents to keep in mind, you know, especially if it's like a pediatrician looking at a growth chart and saying, you know, oh, they're really low. It could be that they're not using the right growth chart as well.
Yeah, there's a specific one that my pediatrician uses for my daughter because she has Down syndrome.
Yes.
And so
Yes.
she's much shorter than a typical kid, and she weighs a lot less than a typical kid. So it's like she's perfectly fine on the Down syndrome growth chart, but, you know, if she was on a typical growth chart, it would definitely be low and underneath where the curve is. So,
Exactly.
yes, yeah. And we talked a lot about food, but what about like water intake? You know, I know a lot of people struggle to get their kids to drink enough water. Like, what's appropriate amount? And if your kid only wants to drink juice or milk, you know, is that okay?
This is a big one, of course, with the hot weather. So Rachel has been going over this with all the patients, so go for it.
Yeah, so it is we do it based on weight. So based on the child's weight, we get a ballpark number. You know, I like to joke around and say, you know, every adult is supposed to drink 8 8-ounce glasses of water a day. Yeah. How many do we know actually do that? So it gives us a ballpark number, and then we look at the patient, and we also see, you know, are they using the restroom adequately? Are they showing any signs of dehydration? So we have a ballpark number based on the weight, and then we assess from there. And if it's way lower and, you know, maybe they're having issues using the restroom, that tells us that we need to increase. And we don't go 0 to 100 either. So if we can increase by a little bit, reassess, and go from there. But as far as juice and milk goes, I mean, we have guidelines for milk specifically. Generally speaking, the recommendation is 16 to 24 ounces of cow's milk a day. We don't generally want more than that because the one thing milk doesn't contain is iron. So we don't want to displace iron containing foods. And from the juice perspective, the sugar content and empty calories and, whatnot. But I'd say milk is probably a big one that I hit on quite a lot.
We try to limit juice to
4 to 8.
Yeah, 4 to 8. And so if
wanna
your
make
child
sure
always
we
wants to
agree.
drink juice, you could try like diluting it some and then kind of gradually diluting it more. And other things come as liquids too, like watermelon, cucumber, popsicles, soups, other things that you can get some liquids in as well.
So we've had a lot of issues with constipation, and I know drinking a lot can help alleviate some of that. It's definitely a struggle in our house. And with my daughter specifically, we do have her on Miralax. And so one is Miralax, does that cause dehydration? Can it? And then two, is there too much usage of Miralax? Like, if your child isn't going and then you give them more, like what is your, like, what do you tell parents? Because I know a lot of people are very concerned about Miralax. When I first started with a speech therapist with my daughter, that speech therapist specifically, she said, oh, don't get her on Miralax, you'll never get her off of it. But then we tried all the natural things, and then Miralax was the only thing that really worked to get her going. We could go like 5 to 7 days without pooping, and that's way too long. And so now she goes every day, and she's on Miralax, and I don't see an end to it, unfortunately, but it's getting her to go. But then, is it too loose? Isn't it? So a lot of questions wrapped up in that, so go.
And we've had a talk before about the constipation and other things. There's a lot that goes into the constipation. Why aren't they going? Do they not want to sit on the potty? Do they withhold? Is there other muscle problems, whatever? Is there stigma associated with it? Is it just an unaware feeling, motility? So we got to figure out all that. But then Miralax is great because it's gentle, nothing's absorbed in the body, it just brings water into the intestines so they produce a nice soft stool. And I know there's a lot of controversy about Miralax and people with behavioral issues or other things, but I have so many kids that's all it works. That's what works. And if it works, we're all for it. We've had kids that have been on it for years and have never had problems. We've had kids that have been on it for years and gotten off of it and not had an issue. So I don't think it's a lifelong thing. It's more getting the body regulated, making sure to avoid bowel distension, anything you can do just to keep the body excreting and having those stools. Yes, water makes a difference. Are you going to get dehydrated? No, because the body's not going to get rid of excess water necessarily through the Miralax that way. Miralax doesn't work as well unless you have enough water in there. So you're not going to get dehydrated, but you do need water to have it work. So each capful should be in 8 ounces of liquids or around there. And then based on heat, other losses of fluids, you got to make sure you add more water in too. Is there excessive oral secretions? Then that's not going to help how the Miralax works because you're not getting enough fluids. Does that make sense? Okay.
Another thing that I'm sure other people deal with Miralax is that, it's not solid. It's a lot looser, and a lot of times from school, previous schools that she went to, people would be like, oh, your daughter has diarrhea. And is there a difference between diarrhea and loose stool? Because I feel like there is, you know what I mean? And I don't know how to explain to these people that no, she doesn't have.
Right. Diarrhea usually is in the number of stools you go a day. So if it's more than 3 or 4 a day. Watery. loose stools, sometimes it's very close, but diarrhea definitely needs greater than 4 stools a day,
Oh,
3
okay.
to 4 stools a day. So it's the number more than anything else.
Yeah.
Because I get patients coming in all the time saying she's having diarrhea, but she's only having a loose stool,
Like once.
once a
Yeah.
day.
My daughter, sometimes she would, save it up, and then it would just be like a fountain for like, and that's fun at school. She would just be like,
Yeah, they love it there.
yes. Yeah. But I feel like at the school she's at now, they at least understand that, so that it's not as big of an issue with them anyway. But whenever I hear that, oh, she's got diarrhea, I like shake my head because I'm like, no, it's not really. But then, of course, I'm not a doctor. I don't know what I'm talking about.
Well, they have their tough rules that they have to follow, that if anybody has diarrhea, they have to go home. And yeah, we have a lot of kids that we want them to have loose stools because as soon as it gets any substance, they withhold and have more problems. So yeah, it's a tight balancing act, and sometimes we have to work with the school and provide letters saying that it's okay if they have loose stools as long as they don't have greater than 3 stools during their time they're there.
So I don't know much about like tubes and tube feeding, but I don't know if you can talk more about that or talk about that. Like, how long does a child usually need one? I know a lot of parents may be nervous about starting their child with one, and how do you reassure a family who, or a parent who's going to have that procedure done, and what things do they need to look out for that they might need a G or tube or G tube, or I know there's different ones. So,
Do you want to start with like what you tell families and then?
It's a long conversation. It's a long, several meetings sometimes. Sometimes parents come in and they know about G-tubes. They had a friend, a relative, or somebody with it, and they want a G-tube. Usually most of our kids that we start feeding will be with NG tubes, the tubes that go in the nose down to the stomach and taped to the outside, and the families are trained in how to replace it. In that conversation, we have to talk about you can still feed the child orally while they also get NG tube fed, in different calories, and how are they doing it? Are we doing overnight feeds? Is this just supplemental feeds? But the big thing, once they know the child can still eat, they feel better about it, because we don't want to take away that urge to eat. And then once they have the NG tube, most kids, especially the ones coming out of the NICU, will eventually start to eat. They were born early, they don't have those developmental skills. It takes a while, a lot of practice, a lot of therapy, and suddenly they're eating, and then we can get rid of the NG tube. There are a few that maybe we're not able to do that. So then we have to talk about a G-tube and a long-term feeding plan. And I have some people that have children with NG tubes that do not want a G-tube. And so we talk about it. It's not something they're interested in. They're okay with putting in that NG and replacing it on a regular basis, because you'd have to replace it every month unless the child pulls it out. And there's some other, risks with it. Kids can aspirate if the feeding's going and they pull the tube out. So we have to assess the family. Are they able to replace the tube? Is the child okay with the tube? Is the child gaining and growing appropriately with the NG tube in? And then we assess how the child's doing with oral eating. Is this looking like it's going to be a long-term thing? And then we'll mention G-tubes and say maybe a more secure one would be beneficial, because it's hidden, it's down below, it's a surgical procedure, there's risks with putting it in, but once it's in, you're able to do feeds as well as oral feeds. And sometimes the kids will eat better because it doesn't have a tube hanging down the back of their throat. So a lot of times we'll have a meet with parents of children that have G-tubes. There's websites, and that's where you'll come in.
Yeah. So, I think as clinicians, we can support parents and families to a certain extent. And then I find that, peer support is so important. And so there's an organization called the Oley Foundation. Oley, and it's a advocacy nonprofit community for families on like home nutrition, either IV or tube feeding. And just a way for them to learn from others how to live their best life. So tips and tricks of how to not get the tubing stuck in the car seat, or how to go to school with these things and what kind of things to advocate for. So I try to strongly encourage families to get connected with some sort of peer community or connection so that they can kind of hear the other sides of it. I think that parents feel probably a lot of emotions when their kids have to have a feeding tube. This is maybe not what they envision their child to have or how they thought they would eat. But I want them to know that they can still live a great life. That there's nothing they can't do as far as, things that they can learn from others. So.
And then when we can tell them they can put real food in a G tube versus an NG, you can make pureed meals, and then that helps a lot of families too, because you want to be involved in what the child is eating. Yes, we can buy, we provide blended diets or formulas, but if you can mix up whatever you're eating and put it down a tube, that helps. A lot of kids do a lot better with a G tube. There's not as much vomiting. They can be fed continuously overnight while they're sleeping and then eat orally during the day. You can give medicines down the tube. So there's a lot of pluses. There's a lot of, there's some negatives with a G tube. You have to do routine feeds and all that, and it's not normal, but there's a way to adapt it to make it work. And then if they're still having issues, then sometimes we have to move from a G tube to a GJ tube where it goes through the stomach and into the intestines. And at each stage, we just work with the family as to what will best meet their needs. It's all dependent on the child, the family, and what they want to do. Yeah. Most parents that advance in that from an NG tube to a G tube always feels really scared, and I don't blame them. It's a major concern putting a tube into your child or having them do surgery. But I've never had any family say that they wish they wouldn't have. I think there might have been one, but that was, out of 40 years. I can't imagine. There's always got to be somebody that's not happy about it, but we'll work with whatever they want to do.
And I feel like even, like you were asking about fluids, we have some patients that use it just for fluids and medication. So they enjoy the fact of not having to chase their kid around with a water bottle, or, every day they give meds, it's a fight. Or they just use it when they're sick. Yeah. So, it
keeps them out of the hospital.
There you go. So that's a big one too.
Is that hard though for people who, for kids who, like you were saying, pulling the tube out, or does that happen often with a G tube? Or I know with an NG tube that probably happens more frequently right up the nose, right?
For the older kids, yes. The babies usually will keep it in, but they rub or they'll get their little hands in there. But there's ways we can keep it in and secure it, tape it. G tubes, yes, kids are very good sometimes about pulling it out. But there's only a few of them, and they do it once, and it's not that it hurts them, but it's not something they do. Some kids will use it as a self-soothing thing and spin it or play with it. But we wrap it with ACE wraps. We have tape. We have securement devices. And most times it's underneath their clothes and they don't even know it's there. Nobody else knows it's there until they hook them up. So.
So it's not painful for kids to have those tubes put in? It's
a surgical procedure, so when they do put it in, it is a little uncomfortable, but they don't require a lot of pain medicine, usually like Tylenol or some Motrin. I always, when we talk about changing it, it's like changing an earring. So it's very similar to that. When you get your ears pierced, yes, they do hurt, but it's not unreasonable. So for the first night, we don't usually do anything and then start the feeds the next day. And then as long as the parents are trained, we send them home. And then the parents will be trained in how to change it. And the kids can change it themselves. So I've never had one, but I've watched numerous changes. And the kids usually say it doesn't hurt or it just feels like a pinch.
So on a different subject, acid reflux, like how do you know if your child is having acid reflux or if it's something else, you know? I feel like there's a lot of different things it could be, but usually that sour breath, I feel like, is a good, you know, but, and is omeprazole okay for kids? Because I know, like, for there's been some things they say, oh, you shouldn't be on omeprazole for a long time, and so and other like Pepcid or other antacids, are they safe for kids?
Well, that's always a good, another interesting debate lately. We never used to give the PPIs, the proton pump inhibitors like omeprazole, pantoprazole, Nexium, as much as we are now. People just immediately, when a baby's spitting up, they want to start them on a proton pump inhibitor, and they don't need it. We use it to prevent complications for other issues. All it does is reduce the acid that's in the stomach. It is doing nothing for the reflux. The reflux is just something kids have to outgrow. We give it when the kids are irritable, they're not eating because of the pain, they're vomiting, other things. So there's got to be other things for the infants. For the older kids, sometimes you'll not even know that they have reflux until they go to the dentist, and then they have enamel erosion, from the acid, and then we need to talk about whether we need acid suppression. Kids at night will lay down and they may cough a lot at night, but they don't cough during the day, and then you're wondering, is that reflux? Is there things we can do? Especially, we've all had those big meals where you eat really heavy and then you go and lay down and then you can feel it coming up. Yeah. And sometimes kids will bring things up and swallow it, or they just cough a lot. And then we need to do some testing to investigate how bad is the reflux, and do we need medicines? What medicines will work best? We don't like to use the proton pump inhibitors long term because it can affect calcium absorption, other issues, but some of our kids, we need them on that. It's the only thing that's working at keeping that acid down. And then we have to monitor their nutrition and make sure their bones are okay and everything else. I mean, yes, you can be on them long term as long as you're being followed and monitored while you're on them. Pepcid is an H2 blocker, which is great. You give it, it works, takes care of the acid, and then it's out of the system. You don't have to build up a level like you do with the omeprazole. And it's a thing you use on a PRN basis, which is wonderful. And yes, kids can use those as well. Sometimes they just have spicy foods or greasy foods or whatever that causes some problems. Takis.
So if they come in and they say, oh, you know, I think this is the problem, you know, then we ask like, oh, well, if you're having this before bed, like, what are you eating? Well, I ate a whole bag of hot Takis, then I laid down and I don't feel good. We go, okay, well, that's, you know, but if you go through the, you know, analysis and say, all right, you're not eating Takis before bed, and, you know.
Or maybe it's juice that bothers them, a lot of juice before bed for any age group. Or medicines, certain medicines can cause problems too. So sometimes you'll know that kids will have reflux, sometimes you don't know. So we just look for those other signs. And if you work in peds pulmonary, everything is caused by reflux, they tell me. I don't believe that, but they are always the bane of my existence. So there is a correlation there, obviously. And there are times where eosinophilic esophagitis, is that reflux? Is it just from the allergies? Is that what's causing some of the asthma or other things that are going on? There is definitely a link, but I think we get blamed a lot for things that aren't ours.
Another question that I always have is about fiber, you know, because fiber is supposed to be good, but then it also can be constipating. So what kind of, like, what do you talk to families about? Do you recommend fiber, or how do you balance that, you know?
Will let Rachel take that one?
You want to take
So
fiber?
fiber, yes, fiber is great for you. But along the lines of fluid, as we were talking before, fiber needs something to help it through your system. So if you eat a bunch of fiber, but you don't have fluid to go with it, you may have
Negative effects.
opposite of what you want. Exactly. So fiber is great for us, but there's, generally speaking, two different types of fiber, right? One that absorbs with water, so like oatmeal. When you dump water onto oatmeal, it swells, versus the fiber from, say, celery, for example, where it has more of that stringy texture. Dump water onto it, nothing happens. So I try to explain that as like the same way that it goes through your GI tract, right? So it's like you need the combination of both kinds of fiber, so from your whole grains and your fruits and vegetables, paired with water to keep you healthy. So it's figuring out, oh, my kid eats 3 applesauce pouches a day and they don't drink enough fluid. Now that the pouches are really popular, it's like, okay, are they eating too much of one thing? I mean, we even have kids that have come in and it's like, oh, well, they eat raspberries every day. Okay, well, back to the topic of how many raspberries. If you eat the whole Costco-sized thing of raspberries in one sitting, it can have, negative effects, even though it's a healthy food. So fiber is healthy, having a few servings every day, pairing it with fluid, helps moves things through. And I call it the 3 F's that tend to help you use the bathroom: fiber, fluid, and fitness. So get your body moving, have enough fluid, and a balance of fiber.
And I would say with fiber, you want to increase it gradually. So you wouldn't want to go from 0 to 60 with fiber. So, increasing slowly, making sure you're drinking enough fluids.
So one of my other question was, what does a normal stool look like? What is normal in that regard?
I guess I'll take that one. Unless the dietitians will. Depends. Normal stools can be different for every person. So it's what's normal for each individual person. We have kids that have had bowel surgery, have had ostomies. Their stool is going to look different than other people. We want average. We would like a soft stool, like a log or a pencil-shaped, round, soft, not hard, not difficult to pass out of the rectum, so that there's no pain involved, no blood, no mucus, soft. That's what we like. We avoid the ones that are small, round, hard pebbles. We try to, that's more of a constipation stool, or the really large ones. Those are not good. And then after that, color can vary depending on what they eat. So that's not always a good indicator, other than pure white stools are something that we might need to look into. Dark black stools, there could be a reason for that as well. But as long as it's not all water, there is some pea soup consistency or some texture in there, we're happy.
What about how often?
Once a day usually, but they can be every other day. It depends on whatever works for them, as long as when it comes out, it's soft and easy to pass.
Is there a time like when a parent should be worried about how long it's been since their child is gone? When is like emergency situation?
Which we get asked a lot, especially newborn babies. Breastfed babies can go a week without having a bowel movement, and I don't know why, but it just seems to be more the breast milk is utilized and they just don't have a stool, or they have a stool every other diaper. Some have every diaper, it all depends. When the older kids, it can be harder. Some people say they haven't had a stool in a month, which we find it hard to believe that that happens. But usually we look for the other signs. Is there abdominal bloating, distension? Are they in distress? Is there something else going on? We do the physical exam and look for that.
Appetite's gone?
Appetite's gone, yeah. They're just laying around, not feeling good, just other things like that. Hopefully I answered that right, yeah.
Yeah, because I know that like I've heard that like people can get a blockage, and that has like, you know, how long until something like that? Could you have a blockage in a couple of days, or is it usually that you know that something like that is within like a longer period, you know?
Depends on what's causing the blockage, because kids can have a small bowel obstruction in a matter of minutes and not have any food or whatever. I mean, the motility can be affected in the gut and can cause it to happen immediately. If we're talking a blockage, a buildup of stool, usually it takes several days. But kids can have partial bowel movements where some of it is coming out or stool is coming around a big mass. So there could be a partial blockage in there. It all depends on the exam and the, you know, x-ray, if anything else, to see.
What kinds of procedures are common with like kids with disabilities that, you know, that they, like parents might want to know, you know, like, is it common that kids have colonoscopies or like endoscopies, or like, and what things are people looking for when they do those kinds of procedures?
And that's a good question, because a lot of the parents will come in asking for the endoscopy or colonoscopy. We don't do colonoscopies very frequently in children necessarily. It depends on what their symptoms are. If a child has constipation, a colonoscopy is not going to show us anything. That's not what we're looking for. What we're looking for when you're doing a colonoscopy is you're looking for inflammatory bowel disease. So usually the child will have weight loss, diarrhea, blood in their stool, lab work that was concerning for other things. They will just look sick sometimes. I mean, there's a variety of reasons for why we would do that. And again, it's not a common procedure in the younger crowd. As they get older, perhaps, but there's got to be those signs and symptoms. For an endoscopy, that's a rather frequent thing that we do when we can't seem to find the cause of difficulty swallowing. Why are they vomiting so much? They look like they're having trouble swallowing, and we can't figure it out on the pharyngogram or with the speech therapist. They're not absorbing nutrients right. They're having frequent diarrhea, weight loss, other things. We need to find out what's going on. And when they do the endoscopy, they're looking at the esophagus, the stomach, and the beginning part of the intestines. And sometimes you can see things based on that. You can see furrowing or ulcerations or other things that would cause the problem, but it's not until they get those biopsies that you really know for sure. And the biopsies look at the cells, and they can tell us whether or not they have celiac disease, and you're not going to know that sometimes until you do that test. You might have a suspicion after doing the blood work and that it was the celiac test was high, but until you do that biopsy, you don't necessarily know for sure. There's other things, eosinophilic esophagitis, other things that are going to show up based on that. So those are that's the main test we do, but it's not the first test. We always like to go from least invasive to more invasive, and we don't jump right to doing that. It's not very common to do the endoscopies on infants. We do, but because they use a smaller scope, they're not able to get the biopsies. It's not as useful. Sometimes when you're doing those endoscopies, you find foreign objects. So that's always something. You never know what's in there, and that could be part of the problem too. Or there could be a bezoar, which is hard growth, hard mass of things, food related. Sometimes it's hair, sometimes it can be fiber, I don't know what, and it's just in there, and that can cause problems. So that's helpful to know. We do the upper GI where they come in and they drink barium to watch it go down, just to look at the anatomy. We do that a lot in babies, just to look for malrotation where things aren't in the right place. Is there strictures? Is there other problems like that? Gastric emptying studies are common, where they feed them a food that has a radioactive substance in it, nothing that's absorbed in the body, but it goes down, and then they put them underneath this machine, and it tells how fast the stomach is emptying. And then we can have them come back in 24 hours and do another film, and it'll show whether or not they're aspirating things. So that's helpful for a lot of our kids if we're not sure they're aspirating. The upper GI is nice. When you swallow, it shows you that one moment in time, though, of whether or not you're going to see reflux. It's that one swallow or two swallows. Gastric emptying is over an hour or so. You have more chance of seeing whether or not there's reflux, and then also seeing the aspiration on the next day film. So that's helpful. We do blood work. Blood work shows a lot of various things. We do sedated labs now, which is helpful for the older kids that are developmentally delayed. We'll have them come in, either give them some oral medicine, or sometimes they have to do the gas and put them to sleep just to draw the blood on the kids that you just can't get it otherwise. Other procedures, CAT scans, those are all more specialized and more advanced, and that's where we would start least, work our way forward. Is that about all of them?
Yeah, sounds good to me. Yeah.
Occasionally, we do sweat tests for the kids if we think that they're not growing, because sweat tests, they put a circular tube and then to collect the sweat and put a dressing on it and then bundle the child up and make them sweat. And then they analyze that to tell us whether or not there's a chance the child could have cystic fibrosis. And even though they don't have pulmonary reasons, sometimes it can be GI only, and that they're just not gaining and growing well, and we pick that up, but that's very rare. But that would be the other test we would do.
Very thorough.
I try.
My daughter actually swallowed a Kinder Surprise toy, and we had no idea, but she was throwing up, and she wouldn't stop throwing up, so we took her to emergency, and they said that often kids they get at least, a couple of kids every night that they have to pull something out of them. So I guess that's fairly common. It seems surprising that you would find something. Is there something in there that kids aren't, because she immediately started throwing up. To try to remove it, so things can get stuck in there, and you wouldn't even know they were in there.
Usually your body is pretty smart and says, hey, something's in here that shouldn't be in here or isn't moving, and that's where the gagging, the retching, feeling pressure, a lot of kids will do this, like there's pressure even if they can't tell you what's going on, but the body will try to get rid of it, and sometimes it can block the liquids going down. So if you feed him liquids, as soon as it goes down, it comes right back up. My son was nice enough to do that for me, and when he was older and had a piece of steak get caught and then would start throwing up water, and I couldn't understand it. He's like, no, really, Mom, I'm throwing up. And I'm like, it made him do it. Let's see. Oh, yeah, you're right. So brought him in, and they had to take steak out.
It was just stuck in there?
It was just stuck in there, yeah. So it does happen, but what causes things to get stuck? Sometimes it's things that they shouldn't be eating, Kinder toys, pennies, there's lots of things.
Pieces of food that are too big and not chewed.
Yeah. Or do they have eosinophilic esophagitis or an inflammation of the esophagus that's causing swelling, and that's causing normal food that should go down to get stuck, and then we have to do more of a workup.
Another potty type question, how do you get a child to understand that they need to go potty? I know there's a whole bunch of different muscles in there and that help you go, but when your child doesn't understand what that means, how do you work with that?
Yeah, that's hard, because we all get the sensation, oh, I have to go to the bathroom. You go in, you go to the bathroom, you sit, you relax, let the poop come out, go on about your day. Some kids don't get that, because as you're eating food, it's going down through the intestines and it stretches out the rectal vault, which sends a signal to your brain, hey, I gotta go poop. Some kids ignore that for so long because they've held it, whatever, that it stretches out so much that it's like a floppy rubber band. It just doesn't work as well. So sometimes they don't get the signal, so they're completely full, and you're like, how can you not know you have to go? Well, they don't know. So we have to use the Miralax, other things to keep the poop as soft as possible, keep it going, and allow that to shrink down to hopefully work again. Then sometimes we work with other body signals. When you eat, your body says, hey, food's coming in, I have to go to the bathroom, so, excuse me. So we know that that's just a built-in reflex. Well, a lot of the kids don't have that, so we work with them. We have them sit on the toilet after meals. Don't want to sit for a long period of time, 5 minutes. See if you can distract them a little bit while they're on there, because if you're telling them to relax, I don't know about you, but when someone's yelling at me to relax, I can't relax. Relax! So you have them, you can read a book, do other things, but they're sitting on the toilet. And sometimes that can take a while just to get them on the toilet. You have to sit there with a diaper on first or whatever to get them used to the toilet. Then sit on the toilet, maybe blow bubbles, blow on a windmill type thing, a balloon, other things. Because when you're pushing air out, you can't tighten those muscles. So that helps push things out. And when you're blowing really hard, inner abdominal pressure will help push things out. So if you do it after a meal and then work on getting them to relax, if that doesn't work, we will give suppositories after dinner to help, because that stimulation will sometimes help, and then they'll be able to go. And then there's a psychologist that works with us that does a great job. She runs a group of kids and works with them on their feelings, you know, how to feel that they have to go, and works with other methods like that. And then there's a physical therapist, and they work with certain moves and things to help the kids.
Yeah, we worked with a woman out in Pittsford, but Bushnell's Basin area, Evolve, and
Yes.
Maggie, and she's lovely, working on doing squats and, you know, that kind of pelvic floor kind of stuff. And it's hard because my daughter is nonverbal and trying to, like, even the stay on the toilet, you know, and she's like, I'm not listening, I'm just going to do my own thing, kind of. And so that's definitely a struggle. She's still in diapers, but we have some successes, so we just got to take those and kind of go
Run
from
with
there.
Yeah. And you have to have caregivers that are going to work with you, and people at school that'll do the program and follow along.
I was just gonna say too, and if you're able to talk to the child, and we have a lot that just don't like to use the bathroom at school, for example. It's like, if the kid's able to communicate with the parents, with you, that's, you know, the issue is them holding because they don't want to use it at school, then we figure out, okay, where do we go from there? How can we
Yeah, maybe they can use the nurse's bathroom.
get them a
Maybe
note,
they can-
or the teacher
by
said, nope,
themselves.
you've gone already, you have one pass a day, or something like that, but.
I've heard actually a lot of people struggle with their schools, you know, with like nutrition, you know, that my kid can't eat XYZ, and like then they have like to talk to the school cafeteria people, like, don't make sure my child doesn't eat this. Or I've heard other people say with the G-tubes and that kind of thing, that the school doesn't want them to be at school because they can't, quote unquote, handle that child with those issues. Do you help parents with those kind of things, like getting, like, talking to schools, and trying to reassure the school, like, or sending, I don't know, information to help with, you know, making sure that child progresses?
Yeah, it's harder. In the city schools, it's usually a little bit easier because one of our kids has already been to most of those schools, and we work with a lot of the nurses. We have had to come out here to Webster when they have never had a child with a G-tube. We come out and we'll work with the nurses. We'll have in-services. We'll teach them how to use the pump, how to use the G-tube, how to do the feedings. We work through all sorts of issues. I have a nurse, Sam, who is mainly just PANS. She will come out and teach people. We send pictures, directions, step-by-step instructions, links to YouTube videos so that they know how to replace a tube, how to do everything so they feel comfortable. Because when you go out and you train somebody, they don't always remember everything anyway, so that we have all that support for them. We have a wonderful social worker, Jen, who works with us, who will make sure that we get the letters that the kids need. Maybe they need to have extra breaks, or maybe we want to include them while they're eating their lunch, because they do eat orally, but they also get their tube feed. So can we hook them up and then go to school? So yeah, we spend a lot of time working with the various schools. Sometimes the part that we run into is the diet. Tube-fed kids are easier because obviously we're providing the diet, but some daycares don't allow outside foods. Some schools don't want certain foods there. They can't have peanuts or whatever because of allergies. So it's hard based on those restrictions, but then they have their own regulations of what they have to provide. So it's a lot of communication, it's a lot of talking, and we have a group of people that work together. The dietitians are very involved, the social worker and the nurse will do whatever it takes. Sometimes it's a battle we lose, and then we just figure out what we can do. But you know, for everything you've been through, that sometimes you got to cut your losses. There is one program that we send a lot of our tube-fed kids to that's wonderful, but they won't allow outside food. And if the kid does not like what is being served, then that's tough, and they don't eat during the day, and the parents are having a really hard time with that.
And going off that, I think too is, you know, families are trying to figure out, what did my kid eat at school? What did they not eat at school? What did they drink at school? And it's like, okay, well, what do we know? Let's focus on what we do know and what we can control. Like if there's certain things that we can't work with the school, it's like, okay, they get home at 3:30 every day. How can we set them up for success before they go to school and once they're home from school? So the things that we can, I guess, have better eyes on or more control of.
And we do ask the school sometimes to send us diet histories, and not that they do a great job, which I can only imagine. It's nothing against them. There's so many students and so much they're doing. And what we're looking for is probably a little bit more, but if they can give us an idea, Mary Carriola is great at telling us what the kids eat, how much, and other things, and they're willing to do a lot more than, say, the city school when they're integrated into a regular classroom, and there's a lot of kids, high on their list is not writing down what the child is eating, but sometimes we partner with them, we work really well, we can figure out a way, even just to get a day or two to figure out what the child is eating and how we can help them better.
So we're getting
supposed to be
running
talking.
low on time, but shocking. Oh, you made it through the whole hour, Colleen. If somebody wants to, if they don't have a GI currently, do they just have their doctor refer them to Strong GI or to, and the PANS clinic is usually through specific schools, is that correct?
PANS program is just a part of GI clinic. So
okay.
Rachel and I also see regular GI patients now on Thursdays, a couple days a month, and I know Michelle is seeing some regular GI too. We're trying to be more all-inclusive. Some of our tube-fed kids are also being followed by regular GI. So if somebody is out there and says, oh, I think my child needs a dietitian, the best bet is to go through their pediatrician to start with. A lot of people will have access to dietitians that way. There are dietitians in our program, but there's also some on general pediatrics right there at the hospital. And some people work with certain dietitians in the community. So that's one way of getting started, and then a referral to Peds GI, and then we decide where's the best fit for them. Do they need to go to PANS clinic, or can we be seen in regular GI? Regular GI has 2 other dietitians that work there with both tube-fed kids, behavioral kids. There's one that's dietitian that splits her time between Kirsch Center and us. And then there's a full-time dietitian over there as well that does a great job with tube-fed kids or just normal dietitians. They'll do celiac teaching, specialized diet, specialized what is that carbohydrate diet?
Specific carbohydrate diet?
Yeah, that one. Milk-free, wheat-free, any kind of allergy-type diet. We have another dietitian that works just in allergy that follows our EOE kids. So there's plenty of people. We just have to figure out what the right fit is. So start with the pediatrician and then refer to GI, and we'll go from there.
Awesome. Any final thoughts before we wrap up?
It's up to these guys. They made me come. I just want to see my patients.
No, I think that covered a good.
I think that's
Yeah.
good.
Wow.
Just
Good spectrum.
we're happy to see whoever, if people want to come and see us, we're happy to work with them and do whatever we can to help these kids gain and grow beautifully.
Yeah.
Awesome. Well, thank you, Rachel and Colleen and Andrea. You guys have been amazing, and I appreciate all your wealth of knowledge.
And thank you to
Thank
the wonderful crowd that showed up today.
Yes,
We
to
really
everybody.
appreciate that. Thank you. Thank you.